know me, I'm Tony Gordon. I'm the chief investigator in the UK for REMAP-CAP. And you've got many of the trial team here that you will no doubt know. And just to give you an update where we are, we're open in a lot of sites throughout the UK now, both adult and pediatric. And recruitment has started, as I said, for the flu season. So 26 patients in the last month or so. And so that puts us over 400 patients now with influenza randomized in the UK. And obviously, remembering it's a global trial, there is recruitment going on elsewhere. But again, the UK is roughly half of that. So over 800 patients with flu who've been randomized. So making us sort of way bigger than most of hospitalized patient trials in influenza. So we're already adding a lot of it to the evidence base for influenza treatment in hospital. And again, just to let you know about REMAP-CAP, although we're focusing on flu in the UK, it is studying other forms of community-acquired pneumonia. Some sites in the UK are doing that, many aren't. But overall, we're recruiting around 1,400 patients a year. So it is shows the benefit of a global collaboration. And there have been a number of amendments that have been through. Now, importantly, the last substantial amendment 43 was just recently approved. And there'll be an update at the end around some of the paperwork aspects. So here you can see how recruitment has been going over the last few years in the UK. So the leading recruiting sites, hats off to Milton Keynes, who've done an astonishing job with over 100 recruits. So it shows you what can be done. So well done to everybody else as well, but wouldn't it be great if we could get everybody up to those higher numbers? And you could see, again, the focus in the UK has been the influenza antiviral domain, the dark green, but you should see steady recruitment in some of the other domains that we have open. So appreciate all the ongoing support. And I think hopefully we'll get as many answers in the coming months, maybe, but and probably years, but large numbers. So a little bit of a refresh today, go through a number of things just to update you about the trial, keep you all in contact with us. And remind you, obviously, REMAP-CAP is an international adaptive platform trial for severely ill patients with community-acquired pneumonia. And obviously, the whole design was deliberately designed to be able to adapt in a pandemic and answer questions in the interpandemic period. And being global, we truly are global, to say. So you can see all the sort of regions covered. With the exception of Africa, we haven't got into that continent yet. But you can see there are regional sponsors everywhere. This is how it's managed globally. And we come under the European regulation. And so our sponsor is UMC Utrecht. And again, just showing you the centers, you can see, I should update, there is obviously Africa is involved. They just don't have a sponsor hub. But you can see the large focus in Europe and particularly the UK. And as you saw, the UK is contributing half of the patients into the global study. So I think it shows you the excellent infrastructure that we have in the UK and all the great work you guys are doing. So thank you very much. And just looking here, just so it's showing that European structure in the UK, we've got Lenny Durde and Mark Bonton in Utrecht. And then, as I said, I'm the UK lead, but importantly, the people doing the very hard work here, hopefully most of you know them. You can see many of them online, the trial coordination team, both at Imperial and IGNARC. Could just mute people when you, that's great. And so again, just quickly reminding you of the design of REMAP-CAP. It is this adaptive platform. So the platform aspect is we're looking to include patients in hospital with community-acquired pneumonias mainly. And so that's the sort of outer part of the platform. So do you come into the platform? Are you in hospital with a pneumonia? And then our domain structure is asking, it's almost independent trials within the overarching platform. So in the case of influenza here, we have a domain asking questions about which antivirals are best, whether to give steroids or not, or immune modulation. So you can think of each of the domains as almost like a little trial within the overall platform, and we get much more efficient answers. This patients may be eligible for just one domain, two, or even three domains. And we'll go through some of those criteria, but you get that efficiency, one overarching infrastructure, and that patients can also be in one, two, three, or more arms, depending on what they're actually eligible for. And we share the same outcomes and things like that. And the other sort of interesting feature is the fact it's a Bayesian trial, fully Bayesian model. So that means there's no fixed sample size. We haven't had to make estimations of likely event rates or the effect of each of our interventions. We keep on enrolling, generating more data until we hit predefined thresholds. So this was what brings in the rigor. But just to illustrate how this works, so I think Bayesian trials are new to most people. So just to understand how it works, we say we start with a neutral prior. So if you take here with an odds ratio as the line in the middle, there could be benefit, there could be harm. And the way we've set it up as an odds ratio greater than 1 is benefit. We start with a neutral prior. So we say it's likely that there's no effect. So that's why you see the curve in the middle there at the 1, where there is no effect. And the chances of a big effect, either harm or benefit, is very small. So that's what we say, a neutral prior. And that's how Bayesian works. You start with a prior distribution of the likely benefit of, say, a treatment. And then you randomize patients, generate more data, and you update it. And as you see, it gets a higher peak when you start actually getting more data. There's more numbers included, more evidence of either benefit or harm. So this is looking a little bit encouraging here. You can see the likelihood of benefit starting to show through. As you recruit more patients, you go up on the y-axis, you get slightly more confidence around the data, until ultimately you reach one of these predefined triggers. In this case here, we've shown it where there's a 99% probability of benefit. We would declare this treatment to be beneficial, and then we would stop randomizing to it and say, this is what we should be treating the patients with. And just to illustrate that if you therefore have see a bigger benefit, you need smaller numbers, and a smaller effect, you need larger numbers. And that way we get the right answer, hopefully, in this trial, and at the right time. As soon as we see a clear signal, we can declare it. So that's the advantage of the Bayesian design, one of the advantages. The other aspect of the trial is that we include different pathogen strata. Obviously, pneumonia is caused by different bugs. We started with bacterial pneumonia, and then obviously we added COVID during the pandemic. And we've always had influenza in there, but we've now really focused on influenza. And again, with the Bayesian model, we can recruit all of these patients. Some interventions may cross more than one disease strata, such as steroids, for instance. But obviously things like antivirals would be specific only for the influenza stratum. And then we also have differences around the patient strata and disease state. So what I would say that what these are is with different patients, the strata are whether they're adults or children. We're including them all in the platform now. And we've split the age at 12 here. The reason being is obviously there's both the logistics of how you might enroll the children, and there may be differences for children in terms of consent forms, which teams are looking after them. So that's why we separated all children away from adults. But actually, when we come to analyze, we actually include those over 12 along with the adults, in that we think that they behave more similarly clinically, and when the drug effects, actually we group the older children with the adults for analysis purposes. So that's why it's broken out. Strata are obviously sort of fixed in time, but what we have also is disease states, and these can change over time. So that's why we don't call them strata. But essentially it's another subgroup of patients. And we want to understand the effects of our drugs both in the severely ill, severe state, which is the critically ill patients. And so that's defined as those in the ICU receiving respiratory or cardiovascular support. So in respiratory support, that's high flow nasal oxygen or above, CPAP, intubation, etc., or cardiovascular support, vasopressors, and they're in the ICU. That's the severe state. Everybody else, we deem not critically ill, including all ward patients, and that is the moderate state. And again, just the way the Bayesian model works out is we can treat these as separate subgroups, or we can bring them together as needed if patients actually behave the same way. If the effect of the drug, say the antivirals, is the same in the severe state and the moderate state, they can be combined together. And so with those different pathogens, focusing on the influenza, we've got 3 domains. So just as I showed you on that initial slide about the platform, we have an antiviral domain that is comparing different antivirals. So oseltamivir, baloxavir, the combination of both. And also it's got a control group is the no antivirals, because again, none of these drugs have been shown to improve outcomes for patients in the hospital. And that's why we think it's important that we include a no antiviral group. We are asking the questions in the steroid domain is whether giving dexamethasone is better than not giving any steroids. We've had for a long time for only ICU patients, though, this is hydrocortisone, and this now is just in for those patients who have a shock dose of hydrocortisone. And again, for ICU only patients, we're also asking questions about immune modulation. And so we saw that both tocilizumab and baricitinib, these immune modulators, an IL-6 blocker and a JAK inhibitor, were both beneficial in COVID. And for critically ill patients with flu, again, we think they have the same sort of inflammatory response. So are these drugs helpful? And so again, we're comparing each of these drugs against not receiving any immune modulators. That's the control group in that domain. So just to point out, when people talk about this, talk about the influenza domain, the influenza is not a domain. The drugs are the groups of drugs are the domains. Influenza is a stratum within it. Semantics, but just I think some people get confused, and just what we thought we would just clarify that. So talking about who's eligible for each of these domains, first we start with the platform. And as I mentioned, being eligible for the overall platform, it's any patient almost of any age. So for children, we only go down to 28 days or older corrected gestational age. So neonates are out, but absolutely everybody else age-wise is in at any part in the hospital, in the wards or the ICU, and they're acutely unwell because of their respiratory infection. For the platform overall, again, we've just set a few exclusion criteria that it had to be within 14 days of hospital admission, or if they're sick and in the ICU, then it has to be within 48 hours of their ICU admission, because we think if you're critically ill, our drugs are most likely to work if you give them in the first day or 2. So that's why we have that criteria for the sicker patients. And then simply, only other exclusion criteria are those that are too sick to benefit, which is defined as death is imminent within the next 24 hours and there's a treatment limitation in place. Or on the other hand, they're already too well and they're actually getting better and going to be discharged in the next 24 hours. Again, we can't make these people any better than they're doing because they're already going to get well. So they're excluded. But everybody else is sort of eligible for the platform, other than you can, of course, the patients can only come into the trial once in the 90-day follow-up period. So then within the overall platform, there are specific inclusion-exclusion criteria for the domains, making sure patients are eligible for the different drugs within the domains. And for the influenza antiviral drug, the patient has to test positive for influenza in any type of microbiology test, rapid, laboratory based, it doesn't matter. But do they have influenza? Then they're potentially eligible. And again, we just got some slightly tighter timelines around inclusion, again, because we want to treat these people in a timely fashion. We already think that one of the reasons we're questioning whether antivirals work is it may be too late by the time they come into hospital. If they've already been in hospital for a week with their influenza, it's hard to imagine the antivirals are going to make much difference. So we say within 96 hours, so 4 days of hospital admission, or 2 if it's in the ICU. Again, emphasizing we want to get in early with our treatments. Our other exclusion criteria, if they've essentially already been treated with antivirals, we're not going to see a difference when we randomize them. So we define that as having already received 2 doses of oseltamivir, or if any of you are using baloxavir, which I don't think is happening, if they've already received 1 dose, that's a longer half-life. So we say 2 doses of oseltamivir or 1 dose of baloxavir makes them ineligible for the whole domain because they've already been treated. So there's no point randomizing. And allergy is obviously, if you're allergic to all of them, that would be an exclusion. And just point out, pregnancy is not an exclusion for the whole platform or even the whole of this domain. You can't give baloxavir in pregnancy, but you can give oseltamivir. And so pregnancy can be included. If you have a patient who's pregnant, they can be included in this, and they would, but only be eligible for the oseltamivir or control group, not the baloxavir interventions. Then the steroid domain, essentially, as I said, is not just influenza, but we recognize that probably the only patients who are likely to benefit from steroids is if there's pulmonary inflammation going on. And so recognizing that with the sicker patients, that they at least need some form of oxygen support. It can just be a simple face mask, nasal cannula, but they need to be on supplemental oxygen. And again, our exclusion criteria are trying to time that. For in the ICU, we're a little bit stricter. We say within 24 hours of ICU admission. And the only other exclusions really is if the patient is going to need steroids for another unrelated condition. Obviously, many patients will be on steroids already. So if they're already having steroids, we clearly couldn't randomize them to be in the control group. And then finally, the last domain, immune modulation. As I mentioned, this is only for critically ill patients, so only in the ICU receiving organ support, and it has to be confirmed influenza infection. So we, as I mentioned, we already know these drugs work for COVID. So if a patient has COVID, I would suggest they should be getting these treatments as standard of care, so they wouldn't randomize. And we're not studying it in bacterial community-acquired pneumonia. So flu positive, in the ICU on organ support, critically ill, then they're potentially eligible. And our exclusion criteria, if they're, you can read the protocol, but we're excluding those patients already immunosuppressed, say with neutropenia. If they've got active TB or invasive fungal disease, TB history is fine. It's just if they're actively got TB or they've got the invasive fungal disease, we would exclude them. We don't want to immunosuppress them. And like all the domains, if the patients are already receiving these treatments for another reason, again, we wouldn't stop them. So they couldn't be randomized within the trial. And at the moment, pregnancy is an exclusion for this domain, although we're hoping to allow the randomization to tocilizumab once we get the MHRA approval for that. But for now, it remains an exclusion. And this is a list of the documents that you need really for the influenza stratum. And importantly, what you need to, in terms of training logs, we do need your choices of what domains and what interventions you want to take part in. Remember, that's the sort of modular nature of REMAP-CAP. It means you don't have to take part in all parts of it. So hopefully there's something that you guys want to take part in, that you have equipoise happy to randomize to. The oseltamivir, dex, and baricitinib needs to come from your own hospital stock. but we are providing you with baloxavir and tocilizumab. It's been donated free of charge by Roche to the trial, and there are specific order forms that you guys can request, and the drug will be delivered to your site free of charge. I will pause there and stop sharing, and happy to take questions. I see some in the chat maybe, but if people want to put up their electronic hand, then we can see. So why don't we go Olivia first? You're on mute at the moment.
Yeah, thank you. I think that's my daughter's name. I can't actually rename myself. My name's Mildred. I'm one of the I'm a PI for Bart's Health, and we're open to just pediatrics at the moment. So I'm afraid I've got a few pediatric specific questions, if I may. Is that okay?
I will try my best, but I may go to the team if I need help with the pediatrics bit as an adult doctor.
Yeah.
But yeah, go ahead.
Okay. I'm not sure how many other questions you've got, but I've got quite a few. So the first one is around I guess the whole premise of the no antiviral arm within the flu part of REMAP-CAP. And that's just because on the shop floor, clearly we have clinicians who are quite reluctant because obviously the guidance that we have at the moment, which actually has been recently updated, does suggest that we give antivirals to those who are admitted to hospital. So I guess that's a challenge that we are facing at the moment. And I suspect it's probably the same across pediatric sites. And I just wanted to, first of all, I guess, see whether there was any sort of strong rationale as to why we should be suggesting that we go against sort of the national guidance. I know that sort of the evidence is a bit limited, but it would be helpful for me in terms of when I obviously speak to my colleagues and hopefully try to talk them through.
So, you're right. Obviously, the evidence is lacking. And just to remind people, this was a specific commission call that came from Department of Health and NIHR that specified that there needed to be a control group because there wasn't that evidence there. We have got a letter both from Chris Whitty as this CMO and Lucy Chappell, who's the Chief Scientific Advisor to Department of Health, supporting randomization, including to the control group. So that hopefully that helps with your sites. And then at a individual level, it's one of the things. So one, they may not work, in which case we're giving people exposure, including children, to drugs that don't work. All drugs have side effects, which I'll come back to. Also, if they don't work and actually just drive resistance, then we're causing a problem. We think we're treating we're treating ourselves. We're doing something. As a clinician, I get this. We all like to do something, but if all we're doing is driving resistance to the antivirals, then that doesn't help in the very specific populations who might really benefit immunosuppressed patients in the community. But I could tell you, I share an office with a RAM pediatric intensivist here at St. Mary's, and one of his colleagues said, "No, we're not happy to randomize. We must give the patient oseltamivir." They gave them the oseltamivir. Now I'm trying to remember what bad reaction it was they had to it, and then they stopped it. And of course, this wasn't captured in the trial, and so now no one knows about it. And I say I can't even remember what it was, and so we're not learning that drugs do have side effects. I get they're rare, but if they have no benefit, and you've given the child the I forget whether it was hepatic necrosis or cerebral necrosis, something a rare thing that happened. It was felt to do with the oseltamivir. So that's why I would encourage people. We should randomize and learn. Otherwise, we maybe actually get things wrong. So,
I do completely understand, which is obviously why we're open to the study at my hospital. In terms of, so clearly, my understanding of the literature and the data is that we don't have evidence, but the evidence is lacking more for mortality benefit. Is that correct? Because symptom sort of reduction in sort of time to, or reduction in symptoms, I guess there is some evidence to Just
Yeah, but it's again more from observational studies rather
okay.
than randomized trials. And so there's always the aspect of if the hospitals who give this, maybe they are the more efficient hospitals that have more guidelines and patients get better because they've been treated according to the guideline in general rather than the specific drugs. But we can certainly send you this letter. I'm keen. You said you had multiple questions. I get this as a really important point about trying to get that equipoise. I mean, if it's too much for your sites, we do allow you not to have the control group and just compare the oseltamivir versus baloxavir. And again, the beauty of the Bayesian model, as long as we have everybody's doing the oseltamivir, you can compare to control. But obviously, some sites have to do control. If we have no controls, we can't do it. But we think it's important that we do have the controls. Otherwise, as I said, some are mild side effects, whether it be GI upset, some can be severe.
Sure. Can I ask one more, and I can put the
Yep.
rest in the chat if
Yep.
that's okay.
Please do.
The other one was around the baloxavir, and clearly, given what we know at the moment in terms of the strains that are circulating, so the H3N2, I do appreciate that obviously at the time when we obviously enroll them to the study, we wouldn't know which one they have. But I recently listened in on a talk, and there was some talk around there being a higher rate of resistance, particularly in children, particularly for the H3N2 strain to baloxavir. And I just wondered whether you had any sort of thoughts on that. Just as you say, we wouldn't know, and it might well be that it wouldn't work or we're driving resistance, etc. But I don't know whether you have any thoughts on that at all. Yeah.
So that is exactly where we are collecting swabs on patients so that we can monitor for resistance. As I pointed out, that's one of the reasons why it's so important to randomize the patients. Because if there is no benefit and all we drive is resistance, we are making things worse. Whereas if they are having benefit, then maybe we accept that there could also be driving resistance. I happened to be on a call this afternoon with UXA to discuss resistance and making sure we're monitoring carefully. So if there is anything update on that, I'll let you know. But certainly, I mean, that's not the only strain around. There's still H1N1. So that's why I think it's included, and we're capturing that information. So hopefully we will learn.
Thanks. I'll put the rest in the chat, and hopefully someone's able to answer them for me because I think they're quite crucial. I can put them on now.
If you put them in, we'll do them. I'll try and type answers to them when we're going on.
Thank you.
Just
Thanks.
the ones that are written in the chat already tried to answer about the single dose of steroids. It's if they've had a single dose, they're okay to be randomized. If it's not continuing, if the plan is to continue, then they can't be randomized. But a single dose of steroid that stopped, that was given in the emergency setting, that's fine. They are still eligible. Obviously, make sure the clinical team know that they're being checked. They're happy to randomize because obviously, if they get in the control group, we want them not to give more steroids. Then Anna, you go to this alternate between hands up and chat. Can't hear you though. And it doesn't look like you're on mute, but still can't hear you.
I think she's going to type it in the chat.
Okay. If you type it in the chat, I was reading Iomi's text about the 5-day treatment. So the how long is the 5-day treatment, and do you carry it on at home? In our protocol, we say it could stop when they went home. So the protocol only says you carry it on for up to 5 days in the hospital. If you want to give it to the patients at home to complete the 5 days, that's okay. The protocol doesn't forbid that. That's absolutely fine. It's just that we didn't want to start specifying what happens at home, and we're certainly not monitoring what happens at home. The important thing is not to give it for more than 5 days if they take it home, but they could take it home. It's standard stock, so there's no issues with taking it home. So you could give them, in that case, the 2 extra days. Should we go to Irina? Your hand up.
Hi, thank you. Can you hear me?
Yep.
Yeah, okay, I don't put my video on. So in adults, we have this problem in our hospital because our protocol in adults still says start oseltamivir from admission. And we are missing a lot of patients because they already had 2 doses by the time that they are approached. Now, my question always was, and in our hospital, we do not recruit to control because of that. My question always was, why can't we just randomize in arms that are oseltamivir and oseltamivir 5 days, oseltamivir 10 days, and oseltamivir and baloxavir?
The reason, yeah, good question. Happy to explain. The reason being is, as I mentioned, the way the analysis is, we can compare your patients to randomized oseltamivir versus baloxavir, also to, in a sort of network type analysis, to controls in other hospitals. So I can see Tony Rostron, for instance, on the screen. I don't know what his side are doing, but if his side is randomizing also to control and oseltamivir, we can use his control patients because we got a common link. You can compare them across there. The important thing is, though, the patients must be very similar. Obviously, there will be difference in Newcastle to where you are. But if the criteria weren't the same in all the hospitals, there would be differences, and so that allows it. So that's why we have to make the criteria sort of specific across the whole domain. So that is why we do that, so that the patients are the same to allow that analysis.
Yeah, thank you, Tony. But still, we are allowed to not recruit in control. And the argument of patients being different in Newcastle, but that's the whole point in getting a lot of patients, because Newcastle can have 100 patients, we can have 12. So you will still get differences. So I'm still wondering if you can think about this, because it will allow us to recruit more patients.
I get that. I would love you to recruit hundreds of patients, and if we could, but I think it's important that the methods have to be robust. And if we recruit different types of patients, so we can cope with differences between Newcastle and where you are, because we learn that about the sites. So the risk of turning this into a stats lecture, which I'm probably not qualified to give, we adjust for the differences between Newcastle and where you're based, because we will learn that about your patients. So if your patients do much better than Tony's patients, because you're in a wonderful hospital, we will capture that over time, and that we adjust for that. What we can't adjust for is the unknown differences if you recruit a different population of people, because you're doing things very differently because you're using different inclusion-exclusion criteria. So Tony, I hope I haven't offended you. I see your hand has come up. I was just using it as a friend, as an example, who wouldn't take offense.
And for clarity, we are recruiting to control for the antivirals.
Excellent. That was
obviously we're in Sunderland and South Tyneside, so a little bit further south of Newcastle. I think the key message that I've heard Tony give is that the funder mandated recruitment to a control group because the evidence does not support routine use of oseltamivir. And I think I hear everyone, and I think this is part of our experience as well, is that it is really difficult to recruit patients, especially when they've been in longer than 24 hours, because the use of oseltamivir is so ubiquitous. But I think there's an opportunity cost in the use of oseltamivir, in the sense that it appears in guidance, but we just don't know whether or not it's effective. And so we need to find out, don't we?
Exactly, Tony. That's exactly right. I mean, we should have run the trial 10 years ago, but unfortunately, for whatever reason, it didn't happen then, and we're trying our best to do it now. And so that's why I would urge as many people as possible to do it. And as I said, these drugs, they're fairly safe. I'm not suggesting they're, but they all have side effects. And that's why we need to learn. So yeah, I totally get this. So that's the idea, premise behind this. So thanks for your support, Tony.
Yeah, I guess the other thing is I wonder whether or not we need guidance or support this year, because obviously the support from Lucy Chappell was last season, and I wonder whether or not we just need that kind of updated guidance, and whether or not we can appeal to NICE to put a health warning on their guidance.
So okay, I will. I doubt NICE are going to listen to us. To be honest, I have mentioned this is flu or steroids. You're talking, Tony?
For flu. I mean, it's mainly the
antivirals rather.
Yeah.
I meant so antivirals or steroids.
I mean, it's mainly the antivirals. I think that's the biggest challenge. But I think, you know, just a kind of an updated version of the letter that Chris Whitty and Lucy Chappell have sent out previously might help. Although, as I say,
you think that'll make a difference with a different date on it? We discussed this just on Monday. We thought like it was last season's flu. This is like
don't know.
That's why I mentioned the letter was circulated, but it takes a while to get their letters approved by these senior people, and so we just thought we'd go with the current letters. But as the second time this has been mentioned, I will definitely write to Lucy and Chris and see if they will support us to help with that. And as I mentioned, I've got a meeting with UXA. I don't know why they haven't included that. We were in their previous guidance. It said consider randomizing to REMAP-CAP. I will mention that to them this afternoon when I have my call in a couple of hours to see if they will update it again like it was previously. I'll tell you what I'll do. I will try and answer some of the queries in the chat text, and I'll hand over to the trial team just to go through a few of the logistics things and so on, so we make sure we do everything correctly in the trial as well. Thanks, Aisha.
Okay. Can everybody see that?
Yeah.
Okay. So we'll just go through eligibility and consent. So just a reminder that we do have a template for the eligibility checklist and statement combined. This is an optional template because sites can still use their own if they prefer to, if they want to. This was just to make things easier for sites, as we had a few requests asking if we had our template. Otherwise, yeah, you can document in the medical notes directly as well if you prefer not to complete an actual template. So just a reminder of the consent process. Once a patient has been identified as being eligible for the study and they meet all the inclusion and none of the exclusion, then their capacity should be assessed. If they do have capacity, then informed consent would be taken from the patient before randomization. If they don't have capacity, then for adults, we would approach a personal legal representative if we can. For children, it would be the parent, but we don't have other personal legal representative consent for children. If there is no parent available or no personal legal representative, i.e. relative available, then we would approach a professional legal representative, which would be an independent doctor who does not have anything to do with the study. And then they sort of just complete a shorter consent form, and then the patient can be randomized. This is with the intention of obtaining consent from a relative for adults or from a parent as soon as they become available afterwards. And again, if we just remember that patient consent must be taken, for, especially for adults, once the patient does regain their capacity during hospital, or if they only regain capacity outside of hospital, it would be during their follow-up period. So it's ideal to check at day 90 or day 180. And just a note here, just to remind sites that all conversations regarding consent must be documented in the source notes and entered on the ETMF. Each discussion should be entered as a separate consent event on the ECRF with an outcome. There is the option of including whether there was no decision made as well, so that should make it easier to document. So a reminder about our consent documents. Currently, our PIS and consent form templates are adapted by us in terms of the treatment sections. And then we lock this section and we will then pass on the templates to sites to add their NHS logo and contact details. We do have our translated PIS documents available now. So once I think Amendment 43 is approved by local RMD at sites, we can provide the PISs and translations that you require. I think we've sent out an email just to try and get sites to give us their top languages that they need. So if you don't need all the languages, we'll just provide the top 3 or top 5 or whatever it is that you need. We also have a consent statement template. Again, this is optional to use for sites. You can use your own templates. We just created this as we had several requests from sites. And just a reminder of what consent form types are available and the formats of consent. So we have written consent, so that this would be the full PIS for written consent, but there is also a section to complete for verbal consent, which requires a witness signature. We have a full PIS for personal legal representatives for adults. We then have the summary PIS consent form for professional legal representatives. We also have summary versions for patients and for personal legal representatives if they request this. So if they say, well, I don't want to read the full PIS, you know, do you have something shorter? Then in that instance, you can provide the summary version. We have a video consent form as well. So there's a video animation. Again, this would be if a patient or relative requests that they don't want to read information and can it be provided in a different format. With both the summary version and the video version, we do require to provide a copy of the full PIS and consent form so that they can read that in their own time whenever they want. But at that moment, if they just want to consent using those summary versions or video consent, then that's fine. We also have a form for telephone or remote consent. So again, this would be, for example, if the relative is not at the hospital yet and you're able to have a phone conversation with them, you can document it on the telephone consent. And then you can obtain written consent when they arrive at the hospital. It's also used for retrospective consent where from the patient, it hasn't been obtained until they've been discharged. So we ask sites to obtain telephone consent first and then to send out the written consent form so that they can complete that and send that back. The reason we ask this is because sometimes they may agree on the phone, but then they never actually send back the written form or it gets lost. And so at least if we have the telephone consent, then there is some form of formal retrospective consent documented. Just a little bit about screening. So all sites should complete the screening log on paper or spreadsheet. And then we can confirm eligibility with a doctor. So that should be documented in the source notes as well. You would then enter the patient onto the ECRF and it would take you through all the eligibility criteria. And then it would let you know which domains the patient is eligible for. And then they would be randomized or they would go to the registry list if it's a screen failure. Just to note about when consent is entered, if you intend on collecting consent but you haven't done so yet, please do not enter no for the consent field. It would be better for you basically need to save the form and come back to it later. if you enter no for consent, what it will do is the system will assume delayed consent, which is where we allow a patient to be enrolled because there's no relative available, there's no professional legal representative available, and it's in the benefit of the patient to just enroll them. And then we have the intention of obtaining consent within 24 hours from either at least the professional legal representative or the relative. So yeah, if you don't have consent yet, but you do have intention, just save the form and then come back to it later. Otherwise, you'll accidentally randomize the patient. And then sometimes, obviously, the patient declines and we then have to delete that record from the database. Just a few bits on other procedures. So with our IMP, this is just a reminder of which drugs are available routinely from the hospital stock. So baloxavir and tocilizumab are the only ones that are study-specific and externally supplied from Roche. We have a study-specific order form, which has been sent out to sites recently. And the baloxavir is just kept at room temperature, so there's no sort of specific temperature monitoring required. It would just be the clinical trial pharmacy. I think most clinical trial pharmacies have room temperature monitoring through their electronic systems, so that's fine. Tocilizumab would be kept in the fridge. Again, you may have an alarmed fridge system, which is fine, or if you don't, then we do have a manual temperature monitoring log template available. So for accountability, again, it would just be baloxavir and tocilizumab that have study-specific templates, and this is for pharmacy inventory accountability only. So we don't require ward accountability. For destruction, again, it would be for baloxavir and tocilizumab. We have templates for authorization for destruction, which would need to be completed and signed by us prior to sort of getting rid of any drugs. So as I mentioned, we do have updated documents. So we have updated order forms and an acknowledgement of receipt form. We also have updated accountability log templates for pharmacy inventory, updated IMP destruction logs, updated temperature logs, and temperature deviation forms as well in case it's needed. There is an IMP pharmacy guide version 5 that is coming. At the moment, we still have the baloxavir manual, but this should be finalized and it should provide some clarity on a few things. Just to note about the IMP shipments with the new process. So we have had a couple of issues. The baloxavir and tocilizumab will arrive with a temperature logger. I think we've had a few issues where sites haven't turned it off, so do remember to switch it off, and then there are instructions enclosed which will let you know how to package and return it to Roche because it is a reusable device. If you forget to turn it off, you probably will receive an email from Roche to say, please can you switch it off. We had a couple of sites that had issues where they couldn't actually upload the data from the logger, in which case you have to quarantine the IMP. But if you email Roche support, they do respond pretty quickly, and if they can see the temperature logger, the data, they can provide it to you and then just confirm that it's okay to unquarantine the IMP. There is a relevant field on the acknowledgement of receipt which just mentions the temperature logger as well, which needs to be completed. And then if you just send us a copy back along with the consignment form, then that should be fine. A reminder about SAEs, we are only collecting related SAEs or domain-specific SAEs for this study. The initial report should always be within 24 hours of site staff being made aware, and then any further details can be entered on follow-up reports afterwards. There is a backup paper form in case the system is down, but otherwise all entry and signatures are done via the ECRF. I think I am now passing on to Millie for the nasal swabs. Oh.
Yeah, I think we're on the wrong slide.
Is that okay?
Yeah. Just to quickly go over the nasal swabs. So these are only relevant to the flu, antiviral, and immune modulation domains. And the kits are provided by us via post. So there are 3 nasal swabs, one on day 1, so the day of randomization, and then day 3 and day 7. And these samples can be kept at room temperature until they're posted. So each sample will have a unique barcode number, and we provide the stickers for this. And you just need to enter the sample details onto the ECRF and complete the swab tracker. The template for the tracker is available on our website. So you just need to post back in the prepaid safe boxes provided. So you can send day 1 and day 3 samples together, but day 7 will need to be posted separately because the samples are only viable for up to 5 days. And you can also send multiple patient samples back at the same time. So just a reminder that you need to remember to add the patient details onto the labels. And also, please don't use your own swabs if you run out. If you just email the study inbox and request more swab kits, we'll send them out to you. And also just to note that if a sample's missed, it's not a protocol deviation. So 5 patient supplies are given at a time per site. So that includes 15 swabs, 15 green tubes, 10 safe boxes, and also barcode labels. Sorry, thank you. So just a note on the new training log. So we've updated the training log to make it just a single electronic training log now, which can be completed following review of the training modules. So you just need to enter your details and select which modules you've completed. And that can be accessed on our website as well. And once you've completed this log, please do send your confirmation email, which will have like a yellow banner at the top. Please just forward that on to the study email. Just a few points and ideas for sharing awareness about REMAP-CAP. So you could put posters by the rapid test machines or around the wards. You could get a research team copied into email alerts from the lab team, so you're notified if any patients are flu positive, for example. You can also put trial alerts in the e-medical notes and share newsletters. And some sites find it helpful to have brief meetings with any new doctors that are on the rota just to make them aware of the study. In terms of funding, the study grant will continue for this winter until the end of 2026. And we're also in the process, we've applied for the pandemic preparedness grant, and that's under review. So if we were successful with this, the study will continue for another 5 years. But we'll keep you posted on that.
Yeah, just to add that we are currently waiting for a letter from the NIHR for the extension until December 2026. And once we do receive that, we will submit it as a substantial amendment and then forward it to sites. I know we're getting really close to the end of November, so that we have had a few queries from a few sites. But yeah, we'll get it out to sites as soon as we can. And then we just have our contact details here as a reminder. If you do have any questions, just you can email us anytime. I don't know if anyone has any questions after the sort of study procedure bits have been presented.
Aisha, there's a question in the chat from Michaela that's asking about whether there are going to be new accountability logs, templates, because it's saying their baloxavir is a different pack size strength.
We did send out new templates to all sites. It's possible we might have missed, but if you drop us an email and then we can get back to you, or if there's an error on the log, we can have a look. Some sites might have the old stock left, and then I think the new stock is packaged and arriving slightly separately. We've had a few changes on how it's packaged, but if you just drop us an email and we can clarify it with you.
Aisha, maybe if you could stop sharing the screen so we just see if anybody else has got their hand up or...
Oh, I have stopped sharing, but I don't know if is it still showing up?
Still showing, yeah.
Is it gone now?
Yep, it's gone
Yeah,
now.
okay.
Just want to see if anybody else has got questions. We're getting closer to 2 o'clock now, so the end of the hour. But if anybody thinks of any questions, please do put your hand up, put it in the chat. But if not, just thank you for joining today. Thanks as always for your participation. And I think just Tony Rostron summed it up quite well. It just remember, this is a commission call from the NIHR to get an answer, because we just don't know if these drugs work or not. And it's important that we do, and particularly with the predicted bad flu season ahead of us. Now is the opportunity to get that evidence that will guide us better. So please do focus on REMAP-CAP for these next few months while we get through the winter period. If that's it, thank you all for joining. We'll keep doing these. I think seeing a number of people joining and questions and so on, we'll keep doing these regularly throughout the whole winter period. We'll think about if there's particular things you want us to focus on, do let us know as well, and we can focus the time on that. I'm very happy to meet regularly.